Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonny Abbara, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Ranganath from Dallas, Texas.
Hey, Dr. Abbara. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Make plans to join us at RSNA 2020. Virtually connect with colleagues and industry partners, explore RSNA's first ever digital exhibition floor and AI showcase, and access more than 350 hours of the latest science and education from every subspecialty. All RSNA members get free premium access to RSNA 2020. This includes CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Register now at rsna.org/annual-meeting. Hello again, listeners. Welcome back to the Radiology Cardiothoracic Imaging podcast. I am your host, Ranganath. On today's episode, we will explore a recently published paper in the August-September 2020 issue of the journal. The paper is titled Relationship Between Coronary Iodine Concentration Determined Using Spectral Computed Tomography and Outcome of Percutaneous Coronary Intervention in Patients with Chronic Total Occlusion. This study comes to us from our colleagues in South Korea. The first author is Dr. Jong-Yoon Lee, and the senior author is Dr. Sung-Ho Hwang. On this episode, I have the privilege of speaking with both the senior author, Dr. Hwang, as well as one of the authors of its corresponding editorial, Dr. Ronan Rubinshtein. Before we dive into these conversations, let's review some terms, the general study design, and the results. First, some terms. Spectral CT has greatly increased in popularity over the last decade, and all major vendors now have at least one clinically available spectral CT platform. Spectral CT is the umbrella term for multi-energy CT that takes advantage of the differential X-ray attenuation of different materials across the spectrum of X-ray energies. Spectral CT can be broken down into two main types, detector-based and source-based. Each comes with certain advantages and disadvantages. The featured paper in this episode uses a detector-based spectral CT platform. Examples of spectral CT applications include material decomposition, characterization, and quantification. The featured paper explores an iodine quantification technique. All right, next let's talk about chronic total occlusions, or CTOs. A CTO, as the name states, is a chronic coronary artery occlusion. CTOs are notoriously difficult to revascularize by percutaneous coronary intervention, or PCI. CTOs have been reported in up to 30% of patients referred for PCI. Certain characteristics of a CTO can predict the likelihood of PCI failure, and these characteristics include a blunt stump, long length, circumferential severe calcifications, and increased vessel bending. Coronary CTA has a growing role in PCI planning for CTOs. The question now is, can spectral CT add incremental value in predicting PCI outcome for CTOs? Well, this is the question that the investigators of our featured paper sought to answer. Now, let's briefly discuss the study design and results. This study retrospectively evaluated 50 patients with a documented CTO who underwent a coronary CTA prior to PCI on a detector-based spectral CT scanner. The investigators collected a multitude of traditional and spectral CT data points. Traditional characteristics included CTO length, calcifications, bending, stump type, and vessel area proximal to the CTO lesion. The main spectral CT characteristic obtained was the coronary iodine concentration in the proximal portion of the CTO. The iodine concentration was calculated from spectral CT iodine no water maps. A low coronary iodine concentration was defined as that less than 2.5 milligrams of iodine per milliliter of blood. The CT findings were then correlated with success of PCI. Now, let's discuss the results. First off, 68% of those 50 patients had a successful CTO PCI. The rest of those were unsuccessful PCIs. Interestingly, a low coronary iodine concentration in the proximal portion of a CTO was significantly associated with PCI failure. The odds ratio here was 16.7 in a univariate analysis. Traditional CT factors like severe calcifications and a blunt stump were also significantly associated with PCI failure, though with a slightly lower odds ratio of 4.0 and 7.7 respectively. Finally, in a multivariate analysis, including both traditional and spectral CT features, low coronary iodine concentration in the proximal portion of a CTO had an odds ratio of 27.0 for PCI failure. Great. Now that we have reviewed the featured paper, let's jump into my conversations with Dr. Hwang and Dr. Rubinshtein. Hey everyone, Praveen Ranganath here. I have with us Dr. Song-Ho Hwang from South Korea. He is the senior author in our featured paper on this episode. Dr. Hwang, can you tell us a bit about yourself, where you're from, where you have trained, and what your current academic specialties are?
Hi everyone, I'm Dr. Hwang from South Korea. I specialized in cardiothoracic imaging, and I completed my training radiology at several hospitals 12 years ago, and now I worked at Korean University Anam Hospital.
Excellent. Thank you so much for joining us on the podcast, Dr. Hwang. I really appreciate your time. Let's jump right into our conversation. Your study investigates the utility of coronary spectral CT in predicting PCI success for chronic total occlusions. Let's focus in on that spectral CT part first. The 50 patients that you included in your study underwent a pre-procedure CTA with a detector-based or a dual-layer spectral CT. Could you talk to us about your CT post-processing and what metrics exactly you were extracting from these CT data?
Yeah, so spectral CT is a very excellent imaging for dual energy CT. Firstly, I reconstructed the CT KV monoenergic images and iodine maps from CT data, and then they are reformatted as curved MPR and cross-section images for evaluation of CTO regions. It's my process.
Excellent. Now, I understand that you were using coronary iodine concentration as part of these virtual monoenergetic images too. Has this method of calculating coronary iodine concentration been validated before in the literature, or is this a new technique?
As you know, in 2013, European radiology, Dr. Kunsen validated dual energy cardiac CT iodine concentration using a phantom model. Then many researchers have studied myocardial infarction and the left appendices thrombus with iodine concentration. Their ideas and the study results were very useful for my study, coronary iodine concentration. And then in basis of this environment and the evidence, I focused on the coronary artery disease and the iodine concentration.
Excellent. So you applied this previous information, not necessarily from the cardiac realm, onto the coronary CTA study that you were doing here. Perfect. Now, you also did some traditional CTA evaluation of those CTO lesions. Could you talk to us more about these high-risk CTO features on traditional CTA that can predict PCI success?
I believe high-risk CTO has a severe calcification and a blunt stump. And as you know, long region length and the small vessel lumen, hyperplasia of coronary artery may be high-risk CTO features. Those represent CTO progression with time in patients with CTO.
Perfect. Thank you very much. And what was your hypothesis regarding the incremental benefit of the spectral CT on predicting outcomes for PCI for these CTO lesions?
CTO may have a small gap, small break, such as microvessels, which may be associated with the structural instability of CTO. So I believe the spectral CT iodine concentration map can detect and quantify a little or a low contrast media in the space of a CTO defect.
Excellent. Interesting hypothesis. Now, I have already briefly summarized the results of your study, but let's recapitulate some of those results here. You showed that coronary iodine concentration immediately proximal to a CTO lesion is significantly lower in those patients that failed PCI when compared to those that had a successful PCI. And this is despite a similar vessel area on CT between a failed and a successful PCI. Could you talk about the implications of this finding?
You summarized a key point well. In this study, I had close attention to ROI, region of interest area, because small ROI may result in over or underestimation in iodine concentration error. So I expect that similar vessel area means the similar ROI area that might have overcome. It's just my opinion. That might have overcome the limitation of selection bias and the small image process. So I had so much attention to select the ROI area, and calculate and reported that areas in the report.
Excellent, but very interesting for sure that the coronary iodine concentration was the more specific metric for determining whether or not someone succeeded in getting PCI compared to the ROI area of the vessel immediately proximal to the CTO. You also conducted a multivariate analysis in your study of the traditional CT features as well as of the coronary iodine concentration in predicting PCI outcome. Could you explain the results of this multivariate analysis?
From my study result, severe calcification, Rubinshtein, and low iodine concentration were important features of high-risk CTOs. This is described, I believe those features describe the proximal entry of a CTO in detail, especially the iodine concentration. For example, high iodine concentration in non-calcified CTO area can suggest the possibility of guide wire passes in the PCI, I believe.
Excellent. So, Dr. Hwang, these results are really exciting. What do you think the hypothesized pathophysiology for why coronary iodine concentration is higher in patients that ended up having a successful PCI? Why do you think that is?
As you mentioned earlier, microvessels, breaks, and gaps of CTO can make the stasis of the passage of contrast iodine and eventually makes the high contrast iodine concentration. Those seem to be a weak point of CTO. For example, the CTO is cancer, and we are surgeons to attack the weak point of cancer. We should find the weak point of the CTO as the cancer, like cancer.
Interesting. So it's like trying to siege the castle in terms of breaking through the CTO. Very cool. So you mentioned a few limitations of your study. Specifically, you talk about resources, about CTA quality, as well as the relatively high success rate of PCI in CTO at your institution. Could you talk about these limitations further?
Yes, that is a very important point. CT angiograph image quality is very important to select the target and select the ROI. We know coronary artery is a very small structure. Beyond the visual assessment, CTA quality affects the selection of ROI, especially in the small CTO regions. So I have emphasized the importance of CTA quality.
Excellent. Dr. Hwang, thank you very much. Now, what do you have planned next for Spectral CT in CTO planning? Is a prospective study on the horizon?
And now, today, I'd like to emphasize this point. The quantification, such as the concentration, is the reliable reference and the threshold to define the specific status of coronary artery disease. As you know, coronary artery disease has a so wide spectrums. So now we begin to evaluate the chronic total occlusion initially at the first step. and I'm going to evaluate that normal coronary artery soon. I wanted to estimate and define the two extremes, bottom and the loop, the coronary total occlusion and the normal. And then, so I believe this step and these processes will help us to understand the iodine concentrations in so many various coronary artery diseases.
So that's exciting. You're going to be exploring not only the CTO population, but also the normal population too, with regards to spectral CTA for coronaries. Great. Hey, Dr. Hwang, thank you so much for your time. I really appreciate it. Thanks again for publishing the study in this journal. I think it's excellent, really interesting stuff, both a combination of new science in spectral CT with very difficult lesions in CTO. Thanks again for your time. I really appreciate it.
Thank you very much.
All right, welcome back, everyone. With me now is Dr. Ronen Rubinshtein, Director of the Heart Institute at the Edith Wolfson Medical Center in Holon, Israel. Dr. Rubinshtein, thank you so much for coming on to the podcast.
Thank you so much for having me.
All right. Dr. Rubinshtein is one of the authors of the editorial of the featured paper of today's episode. I've already spoken with the senior author of that paper, Dr. Hwang, about the specifics of the study. Now, Dr. Rubinshtein, I'd like to hear from you some of your commentary on this study, as well as its greater impact on the field. So first off, let's review what makes PCI of CTOs, or chronic total occlusions, that much more difficult than regular stenoses?
That's an excellent question. I believe that if you look at invasive angiogram, invasive coronary angiogram, in patients with coronary artery disease, you may detect in up to 1 to 5 patients a chronic total occlusion, which means 100% occlusion of the coronary vessels. And while it is, I think at least in my field, it's the business of PCI, or the practice of percutaneous coronary intervention, is rather expected. So you know what to expect. In the majority of cases, you are able to dilate a stenosed vessel with a high success rate, definitely in acute coronary symptoms, but also in patients with stable coronary artery disease. However, because of the nature of this chronic total occlusion, chronic means more than, at least greater than 3 months that it's been there, make it much more difficult to cross. And the success rate of a CTO, chronic total occlusion, PCI, is much lower than with regular coronary arteries. And I would say that it ranges somewhere between 50 to 80% success rate, which is much lower than the higher than 90% that you may see in regular stenosed coronary arteries. And obviously, expertise is part of the equation, but the nature of this chronic occlusion make it much more difficult to penetrate.
Excellent. That's great insight to have on why it is so difficult to cross these CTOs. In the featured paper, they report that they're able to achieve PCI success in nearly 70% of their cases. Do you think that's on the high side, on the low side?
I think this paper comes from an institution and from a country, Korea, which is the PCI CTO PCIs are quite common. I think even more common, and there is more proficiency there than in other places. So I think this is basically somewhere in the middle or in the high middle success rate as reported by others. I would say that only few reports were able to report a success rate of greater to 90%, of almost 90%. And those with the hybrid approach that we may discuss later, what is a hybrid approach for a CTO PCI. But the majority, I think the average is somewhere in between 60 and 70. So this is basically, I think, within the ballpark of what we're talking about.
Excellent. Thank you, Dr. Rubinshtein. Now, let's talk about CT. Dr. Hwang and colleagues mentioned a few traditional CT characteristics for CTO lesions that might portend greater difficulty with PCI. Some of those features were a blunt CTO entry site, vessel calcifications, vessel tortuosity, as well as general CTO length. Could you talk a little bit more about these features, not just on CT, but what you would encounter in the cath lab?
I believe that all those features that were mentioned by the author are basically features that are included in one of the most common CTO scores that are used before planning an intervention. Most of the time, we do not perform CTO PCI ad hoc, which means patient comes to the cath lab, is undergoing a diagnostic coronary angiography, and immediately after you proceed with the CTO PCI. This is usually not the case. Usually you stop at this point, make a decision whether you should perform a CTO PCI, and whether you should perform CTO PCI is a big question. We obviously, there's definitely a debate in the literature about whether to perform it at all, but if you perform it and if you decide to perform it, in very basic terms, it's only in patients who are symptomatic despite optimal medical therapy, or have a large area of ischemia. This is probably and are not amenable or are not candidate for bypass surgery. Those are usually the cases that goes to the cath lab, so a selected group of patients. And in those cases, one of the important, the JCTO score, usually have all those parameters that you mentioned. So calcifications, which make it very difficult to the wire to penetrate, bending of the vessel. So a bent vessel with a narrow angle will make it almost impossible to push forward, because then the vessel bends. So difficult to cross the wire. Another difficulty is obviously whether you have a tapered or a blunt stump. When you have a tapered stump, basically you may push your wire into a direction which is basically in the territory of the lumen. But if you have a blunt entry site, then you do not know when to push your wire, and you may go outside the vessel and create a complication. And one of the so all those things that were mentioned by the authors, blunt entry site, vessel calcification, tuberosity, and the CTO length. Obviously, the greater the length, usually if it's greater than 2 centimeters, the difficulty is higher. So if I take all those 4 anatomic characteristics and add it all and add another characteristic, which is it a retry? Is it the first time that someone has tried to cross this CTO? So all those 5 parameters, yes or no, are included in the JCTO score, and the score which is 2 or higher, defined as difficult case.
Perfect. That's great information, especially clinically to have. For many of us imagers, we don't always necessarily see what the cath lab result is. So it's great to have this correlate. With regards to the featured paper, although it's a small study, there's about 50 patients included, they're finding very similar things to what you're describing. When we do identify these traditional CT findings, such as long length or vessel bending, calcifications, there was a higher odds ratio for PCI failure. One thing interesting that's described in this paper is a novel spectral CT technique. The featured publication retrospectively evaluates a spectral CT technique in predicting PCI success. Are spectral CT techniques in this realm of coronary CT new, or have they been validated beforehand? Could you speak a little bit about that?
Definitely. Thank you for the question. I think this is something, this is really exciting for us, because what spectral CT or dual energy CT brings to the table is the ability to have some tissue characteristics. And I think this is what is novel in this paper. Although the use of spectral CT in cardiac CT angiography has been described in other scenarios, especially for evaluation of myocardial perfusion defects. So spectral CT, which is, as you're probably all aware, the vendors who produce the CT have those different approaches to how to do spectral imaging and how to create material decomposition, or how to create tissue characteristics for us. Some vendors use dual energy, so 2 tubes that produce 2 different energies. Others use rapid KV switching. And what we are talking here is that we create the decomposition, or we create the spectral imaging by dividing the energy of the X-ray beam at the detector level. So just to remind you, a spectral CT is based on the fact that you have a detector that has 2 layers. The upper layer, which is more sensitive to low energy, and the deeper layer, which is more sensitive to higher energies. And if you consider, just again, if we try to bring our imagination to the table, so if we say that light is polychromatic, and if you put a light through a prism, you will have all the colors of the rainbow, then you may consider X-ray also as polychromatic. So if you put it through a prism, and in many ways, the nanoprism panel, this is the name, by the way, that Philips gave the detector, is in a way a prism. It will allow you to detect different energies. So when you look at the computer screen on your CT post-processing workstation, it's not like that you are adjusting the contrast or the brightness. You're adjusting between 40 kilo electron volt and 200 kilo electron volt. You're adjusting the specific monoenergetic image that you get in this specific energy level. And in this way, creating material decomposition and allowing us to better characterize the nature of what we see in the heart. And I think we have only few papers, and this is one of the first to describe the use of spectral CT within the coronary vessels.
This is fascinating. In the paper, they use a 60 kiloelectron volt monoenergetic images in addition to iodine no water decomposition maps. In fact, the key finding in the paper is that the coronary iodine concentration just proximal to the CTO lesions is directly correlated with PCI success. The lower that concentration, the more unlikely we are to succeed with PCI. Can you talk a bit about these results and how they might translate to clinical practice?
Yes, this is very interesting because what I think the authors tried to prove, and if I got it right, is just 2 millimeters distally to the entry site, at least by their methods. And what they found in many ways, it has a lot of logic. What they found that even with this sensitive method of spectral CT, you are allowed to detect higher iodine concentration in the proximal portion of the chronic total occlusion. And this, at least in theory, may reflect two options. First one, then we can see now microchannels. And I have to remind the audience that even a chronic total occlusion many times have microchannels that allow some antegrade flow in the coronary vessel. By the way, those coronary microchannels within a chronic total occlusion are target for probing. We usually start our CTO PCI with trying to put a very thin, a very smooth, a hydrophilic wire through those microchannels. So in theory, the finding of a coronary iodine concentration, which is higher in those who were successful, in those PCI were successful, in many ways suggest either more microchannels or microchannels that we were able later to cross and penetrate, or maybe less calcification and a more fibrous tissue. So the tissue characteristic of spectral CT translate into clinical practice.
Interesting. So is there a possibility of modifying your technique for approaching a CTO based on what we think the tissue composition of the CTO is? For example, in your editorial, you mentioned something called the escalating wire technique. You'll have to forgive my ignorance. I haven't been in the cath lab too often. Could you describe a bit more about this and how you may approach a CTO differently?
Yes, thank you. I think most of the, if I try to simplify what is the approach of an experienced lab to a coronary total occlusion, is usually there are 4 steps. The first 3 steps are different type of wires. The first one is, as I mentioned, trying to probe a microchannel, trying to cross antegrade a wire through those microchannels. Then the second stage will be if you cannot penetrate through a microchannel, go subintimal and entry and do re-entry. And we have dedicated wire for that, or even some fancy devices, crossbows, stingrays, all those funny things that, interventional cardiologists have. But we have some ability to at least to do a re-entry to the true lumen, even if we cross the occlusion, just subintimal. And the third stage will be trying to poke it with a stiff wire, with a heavy wire, and trying to push it forward. So this would be the third stage. And the last stage, if we cannot penetrate the proximal cap of a CTO in an antegrade approach, then this is the hybrid procedure. You'll go contralateral and what we call the retrograde approach, which means trying to cross from a different vessel through some collaterals and go back and try to penetrate the proximal cap from distal to proximal. And those are basically what we're doing. And in a way, this paper may allow us at least to evaluate the possibility, what is our chance for antegrade penetration.
Excellent. This perspective on what happens in the cath lab is great for our listeners to understand the impact of the featured paper. Let's switch gears just a little bit. What do you think were the major limitations of this paper specifically, and also with spectral CT in coronaries in general?
Yeah, so I think this is a good question. I believe at least at this stage, we should be, all of us, modest about how we can implement those findings, because as you're all aware, given the fact that especially many of the large registries or even randomized trials that evaluate CTO, PCI could not prove the benefit, especially on hard events, including mortality and recurrent myocardial infarction. So we have to be very careful, especially this is a very small study with only 50 patients. But the level of evidence, whatever, it's just, again, it's a hypothesis generated. So I think this is probably one of the most important things to remember. However, one important thing that I think maybe at least physiologically need to be bear in our mind is the fact that despite at least my explanation that the higher iodine concentration in the proximal portion of a CTO may be associated with microchannels, and again, this is a good thing, helping us maybe predict a better success. However, please, we have to remember that some of the antegrade flow in a CTO is not with microchannels, is with bridging collaterals. So sometimes the heart itself, the coronary vessel, develop microcollaterals, or collaterals which are outside the lumen. Those are not microchannels within the lumen, those are outside the lumen, very close to the lumen. And they may be mistaken for some connection between the proximal occlusion or the distal occlusion, but those are not. So I think at least with the current spatial resolution, definitely with this scanner, we have only 64 slice CT, I think we are not able to differentiate microchannels from bridging collaterals on a totally even calcified occluded vessel. So I think we still have to take into account the traditional anatomical features when we're planning a CTO PCI. But again, things are moving so fast. So now, when we're moving into even photon counting detectors and maybe other techniques that will allow us a better spatial resolution, then we may be able even to detect better or even higher in a higher resolution the details of what is going on within this chronic total occlusion.
Well, Dr. Rubinshtein, you kind of answered a bit of my next question, but I wanted to ask, what are you excited for next in this field? What do you think are the next steps we need to translate coronary CT or spectral CT specifically into CTO planning and for PCI?
I believe that at this stage, you're probably all aware that the majority of institutions do not use spectral CT or not even plan for a dual energy CT in cardiac patients. I believe that if this result can be repeated and can be replicated in larger scale studies, I believe that may be one of the options to evaluate a CTO upfront, because again, given the lower success rate of a CTO PCI, any piece of data that may give us some kind of a crystal ball, what will be our success rate, is definitely wanted and needed. This is again an unmet need, because many patients do not go to bypass surgery. Many patients have no options rather than to undergo a CTO PCI. And again, if we're talking about 1 in 5 in the cath lab, this is a large number of at least potential candidates for the procedure. So any prediction tool, including spectral CT, will be helpful. May I add to that let's try to go out and do not have a tunnel vision or a sixth French vision, and we're going outside the coronary arteries. Then spectral CT has other important implications, including the ability to detect perfusion defects, to see whether this CTO is again generating ischemia or perfusion defect in the myocardium. We may also use spectral CT to decrease our amount of and severity of artifacts that we sometimes see with regular filter back projection. And I think we have, I think there's definitely a great future for spectral imaging. Doesn't matter if it's dual energy or in the detector level. Again, the technology doesn't really matter which type, how do you attack the problem. But I think we should all also consider in our mind that the most important thing is physiology, not just anatomy. We talked in the last minutes only about anatomy, but is physiology. Is it indeed creating significant ischemia? We know from PET studies that in the majority of CTOs, there is some of ischemia. So usually their PET scan is abnormal, but whether it's clinically significant, I do not know. And given the last publication of the ischemia trial, that even patients with moderate to severe ischemia, they did not benefit from PCI in addition, or revascularization in addition to optimal medical therapy, especially in stable patients. I think we should be really careful in evaluating what to do next. Because again, in a word of caution, CTO PCI is very exciting, but is also associated with higher complication rate.
Perfect. Dr. Rubinshtein, this is really exciting. Thank you so much for taking time to join us on the podcast and discuss this topic. I really, really appreciate it.
Thank you so much. And I wish you all the best, and stay safe, all of you. Take care. Thank you.
Appreciate it. You too. Take care and stay safe. And to our listeners out there, if you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, my name is Ranganath, and this has been the Radiology Cardiothoracic Imaging Podcast. See you next time.